It's my honor and pleasure to welcome Venkatraman, Venki, Ramakrishnan to this conversation in the Kerala Dialogue series. As many of our viewers know, Dr. Ramakrishnan is a Nobel Prize-winning biologist. He was awarded the Nobel Prize in Chemistry in 2009 for his studies of the structure and function of the ribosome, for revealing in unprecedented detail how living cells make proteins. In other words, for providing deep insights into the secret of life. He is president of the Royal Society, elected to a 5-year term in 2015. He's the first India-born scientist chosen to head the world's oldest scientific academy, following in the footsteps of scientists like Isaac Newton and Ernest Rutherford. He's group leader at the MRC Laboratory of Molecular Biology in Cambridge. India's second highest civilian honor, the Padma Vibhushan, was conferred on him in 2010. He was knighted in 2012, but never uses the title. I know that if I address him as Sir Venki, he'll immediately put a stop to this interview, maybe walk out. How should I address you, Dr. Ramakrishnan?
You can just call me Venki. I mean, as you always do, Ram.
And there's a backstory to his rise to scientific eminence that is fascinating and can be read in an autobiographical essay available at the Nobel website. I had the pleasure of publishing this long-form essay in the Hindu at that time. You'll remember, Venki.
Yes, I do.
You're good enough to offer
it. In fact, you were the only newspaper I offered it to.
Yeah. Yes, thank you. Let me compress this backstory as much as I can. Born in Chidambaram, Tamil Nadu, moved to Baroda, now Vadodara, at the age of 3. Academic parents, father head of the Department of Biochemistry at the Maharaja Sayaji Rao University, mother a psychologist with a doctoral degree from McGill University, Montreal in Canada. Schooling at the Convent of Jesus and Mary, took a BSc in physics, studying on a National Science Talent Scholarship from the Maharaja Sayaji Rao University in 1971, moved to the United States at the age of 19 and got his Doctor of Philosophy degree from Ohio University in 1976. Not keen on pursuing a career in theoretical physics, drawn to biology where great fundamental discoveries were being made. So spent 2 years, believe it or not, as a graduate student, even taking undergraduate classes, learning the basics of biology at the University of California. Began work on ribosomes as a postdoctoral fellow at Yale, turned down for a faculty position by about 50 universities. Is that right? I read that. Is that right?
That's right.
And the rest is part of the history of contemporary science. You can read about this in his wonderful, widely acclaimed book, Gene Machine, to the race to decipher the secrets of the ribosome, which was published in 2008, and I have an autographed copy here, this book. Our viewers must, those interested in the subject must not miss this book. It's a wonderful book. It's a personal story, and also it's about the science itself and the race to win the Nobel, among other things. So welcome, Venki, and it's very good of you to find the time.
Thank you, Ram. Good morning, or good afternoon.
Yes. You said in your Nobel biographical essay that the feeling of being an outsider has remained with you for much of your life, as your career has taken you to various countries and also to different disciplines, I guess. But you're now very much an insider. For the last 5 years, you've been deep in the heart of the British scientific science enterprise as the president of the world's oldest scientific academy. So that's a sea change, isn't it?
It is. I think my claims of being an outsider are wearing thin because, you know, I'm also a fellow of Trinity College. I'm at one of the world's most famous molecular biology labs, you know, president of the Royal Society. So people say, what do you mean you're an outsider? But I think, you know, I'm still an outsider in the sense that for example, I live in Britain, but I didn't grow up here. So I didn't form those networks that you form when you're an undergraduate, a graduate student, a postdoc, etc. And so you have a cohort of people that you've sort of grown up with and built careers with. And so in that sense, for example, I was a bit surprised that they even chose me to be president of the Royal Society. And perhaps, if they had known that immediately afterwards there would be Brexit and then now this pandemic, maybe they would have chosen somebody else, who was more sort of familiar with how the establishment worked and had better contacts and networking and so on. On the other hand, being a bit of an outsider has an advantage also, because people don't perceive you as part of a particular clique, this or that group. They don't see you as having a particular agenda, and they tend to take you more at face value, precisely because you don't belong to some, particular group. So I think, one has to embrace, this sort of feeling of being an outsider and not be bothered too much by it.
As president of the Royal Society, you took the initiative early on during this pandemic to convene a multidisciplinary group. You call it DELV, Data Evaluation and Learning for Viral Epidemics. And its remit is to support a data-driven approach to learning from the different approaches countries are taking to manage around the pandemic. And DELV has been providing input to the UK government through SAGE, its scientific advisory group for emergencies, of which you are a member, of which you are a distinguished member. How has this effort gone?
It's gone well. First of all, I should make a slight clarification about SAGE. So SAGE does not have a standing membership. It is a group that is formed on an ad hoc basis to deal with emergencies. So for example, if the emergency was the Iceland volcano, which shut down air travel and so on, there would be a different group of people convened by SAGE to deal with that. Or the Novichok poisoning incident in Salisbury, they would have, toxicologists, terrorism specialists, etc. It just so happens that in this particular, and I should say often SAGE will meet 2 or 3 times, deal with the crisis, and then it'll just be disbanded. This particular SAGE has met 47 times so far, and that's very, very unusual. And I also think the people who participate in SAGE, even during this pandemic, change as the nature of the questions change. So perhaps in the early stages, you might need certain types of people. In the later stages, you might need other types, or you might need to add other expertise. But what happened when I set up DELV was that the government chief scientific advisor, Patrick Vallance, welcomed the effort, because his view was that any input we can get at this point is going to be welcome. And he also said, well, why don't I arrange for you to attend SAGE meetings so that you can see what we are concerned about, that can direct your efforts, but you can also provide input. When you carry out a study or learn something, then you can directly let us know, and that way you can make sure that your work is heard by the people who are going to actually make decisions. The other aspect you alluded to about data-driven, this was our original goal, and we do have some very distinguished data scientists, experts in machine learning, data analytics, and so on. And in fact, one of the people who founded DELV along with me is Demis Hassabis, who's one of the world's most famous machine learning experts. He founded DeepMind, which is considered one of the leading machine learning companies in the world. You may know that one of their big successes was to beat the world Go champion. and then within 24 hours, the program learned to play chess by itself with no human intervention, and it eventually became the strongest chess program in the world, and even stronger than any human. So we had a number of excellent data scientists, but the problem was that the data itself is not so easily accessible. Other countries will only release aggregate data. They will not release granular data. For example, even anonymized patient records and outcomes and so on. So the data part has gone well. I mean, we have an economic study which uses credit card data to look at consumption and purchasing during the pandemic. But much of our work has involved what I would call expert review of the literature. Because when you have the literature, there's lots of bad papers or poorly carried out studies. And if you simply include all of this in your analysis, you may not come to the right conclusion. Now, people may call this cherry picking, but actually, if papers are ignored, they're for a very valid reason. It's not just because you don't like the result. So using that combination of looking at whatever data we can get and reviewing the literature, we've come up with a number of studies. For example, the use of face masks, quite controversial in Britain and in much of the world. Even the WHO and the CDC initially were against the use of face masks. They thought it had very little impact if the general public used it. And our view was that it actually could play an important role in transmission control. It's not an end-all and be-all. Just because you wear a mask doesn't mean the pandemic is suddenly going to go away. But it's an important mechanism along with other measures. Another study we did was the contact tracing and the use of apps, what you need in contact tracing, because there are lots of questions in contact tracing. First of all, how do you even define an index case? That is the original case that triggers contact tracing. Because lots of symptoms may not be COVID at all. They may be related symptoms. And so at what point do you decide this is an index case? And do you test the index case? I think the answer has to be yes. And then you have to decide, what is a contact? Is it someone that you transiently passed outdoors? Is it someone you were indoors with for half an hour? So those are two extremes, but somewhere in between is the boundary for where you define who is a contact and who is not a contact.
Venki,
and then you have to decide.
This will be of great interest to Kerala, where there's quite a contact tracing story, but we'll come to that later.
Yes, Kerala, I know, has done an admirable job. So there are all these questions, and so we produced a study on contact tracing. We then produced a study on nosocomial infections. It turned out these are hospital-acquired infections. And it turns out that after the initial peak died down, there was a longish tail, and this is because hospital infections were still going on, and these infections were seeding community infections because healthcare workers would go home and they might infect their families or others that they came into contact with. So we did a study on what are the issues with hospital-acquired transmission and what can be done about that. And we're producing a study that's going to be very important on schools. Now, schools, the opening of schools is a very controversial topic because teachers very rightly are concerned about getting infected and having to work in unsafe environments. On the other hand, children are suffering quite serious problems of education, mental health, etc. And they really do need to go back to schools. So the question is not whether schools should be opened, but how should they be opened? How to make schools safe? to reopen. So these are all issues. And then we're going to talk about, have a future study on the economics of COVID and how to balance, how to try to balance economic and health issues, which is, of course, a problem in every country.
Yes. Now, on the virus itself, Dr. Anthony Fauci, the iconic physician, infectious disease specialist, and the public face of the COVID-19 pandemic in the US, or the response to it.
Or he was, anyway.
Yes.
Yeah.
Sees SARS-CoV-2 as a unique virus. In his words, I have read, there was an interview in the New York Times yesterday, and he's spoken on it. And to quote, "I've never seen a virus in which the spectrum of seriousness is so extreme. The disease goes from nothing to death." Now, the question for you, Venki, is, as a biologist working in a lab site on fundamental issues in science, do you see this COVID virus as unique, deserving respect that has not yet been given to it?
Well, you could argue that any virus is unique. So I wouldn't put too much store by that. I think what he might have meant is that viruses are usually either very benign or they're quite serious. And coronavirus seems to have a wide spectrum. The thing I would say is something that my sister Lalita, who's also very well-known infectious disease specialist, says that coronavirus doesn't intend to do any harm. In most patients, it reproduces and then reinfects other people. Okay, so it just wants to live. And a lot of the seriousness of the coronavirus is caused by our reaction to the coronavirus. So it's our immune system and our inflammatory response, which is actually driving some of the seriousness of the in some patients.
It seems to have some kind of demonic power of transmission, which is new.
It has a higher what you call attack rate than many viruses, but it's not the worst. I mean, measles, for example, is far more infectious than coronavirus. It's just that we're no longer worried about measles as much because we have a vaccine to measles. Yes. And so it's not considered as serious a problem, although there are these nutty, I don't know if you have them in India, but in the West, there are all these nutty anti-vaccination people who have caused lots of deaths because they won't vaccinate their children against measles, and then you get measles outbreaks.
Now, your own studies of this virus, can you tell us a little bit about it in an accessible way so that people can understand your own?
How do you mean my own studies?
In your lab.
Oh, I see. Well, it's not a very good story so far, I should say. So the virus makes a large number of proteins actually in one go. It's synthesized as a very long chain, and then there are proteases which essentially cleave this long chain into lots of different proteins. One of them is the polymerase that replicates the virus. So it's an RNA polymerase and it replicates the virus. The other is a protein, a small protein called NSP1. NSP stands for non-structured protein. So these are not part of the viral architecture. They're functional proteins. It's called NSP1, and it was believed in SARS to shut down translation of proteins by the ribosome. Okay, yeah. So we thought, well, we could understand how this protein actually interacts with the ribosome and stops the ribosome from working. Unfortunately, before we could make any headway on it, 2 other papers came out from Germany and Switzerland doing exactly what we had wanted to do in the first part of the problem. So our question now is whether we should continue, because this question still is, how does this protein shut down the ribosome for making the host messages, that is our own human proteins, but still allows the ribosome to make the viral proteins? Because if it shuts down the ribosome completely, then it too won't be able to replicate itself. So that question is still an open one, but we're wondering whether, if these two groups are that far ahead, whether we should really even bother. So at the moment, we're not actually doing anything. So I'm sorry to have to say, that's life. Even if you're quite a senior scientist, the perils of being scooped are always there. But you know that from journalism. You could be the top newspaper and still get scooped, right? So
it's very much part of your book.
Yes, that's right.
Now, based on personal observation in India, in Chennai in particular, and also from what I read, it appears that to many young people, this virus appears to be no big deal. 20 to 40% of the infected have no symptoms. Others get mild symptoms, which can be managed at home. And only a minority, older folk with comorbidities, get into real trouble. And the infection fatality rate, as you know, is currently estimated to be about 0.6% worldwide. It could be, I don't know what it is in India. So what would you say to these young people and also middle-aged folk who go along with it? One other thing, Venki, I observe from my personal observation, there are two extremes. People who are extremely fearful, extremely insecure, won't come out of their homes. And on the other side, people, I see them all over the place in shops, masks pulled down and worn like a scarf, and wandering around. You know India as well as...
Yeah, well, I'm afraid it happens here as well. You know, I live in just outside of Cambridge, and if you go to some of these river, along the river on a weekend, and we've had a glorious summer, and you'll see all these young people. None of them are wearing masks, of course, and there's no social distancing at all. They're all, right next to each other. So I think this is a very difficult problem, because young people often are at the beginning of their career, or they're in education, and their lives have been disrupted. Their jobs have disappeared, or they're being furloughed, or their universities have shut down. And they're not the ones who, generally speaking, get, serious illness. So you can see why they might think, why is the entire world shutting down when, and why are we paying the price, the major price? Whereas these senior people who are most at risk are also often the most secure. Many of them have finished their careers, they're on pensions, or, they have a secure life, etc. So this could lead to what I would call a generational strife between the young and the old, and it is an issue that we need to be honest about and try and tackle head on. And the way I would think of it is this: young people may not get symptoms, but by not being careful, they're keeping the virus alive. They're keeping the virus endemic in the population. And by doing so, they're going to infect lots and lots of people, many of whom will die. Now, not all of them will be old. There will be young people who will also die. It's not entirely true that it depends on whether you have, diabetes or, other problems. We still don't know enough about the virus. And many people who get illness and recover, we simply don't know what the long-term effects are, even though they have recovered from the virus, because it's a very new virus. So, and then you might ask young people, would you want your parents or your grandparents I think if you take the attitude that we in society should be in it together, and we should sort of look after each other, and regardless of generation, and that it is a temporary sacrifice, then many young people might be convinced. But you have to be honest with them and not be patronizing, I would say.
Thank you for that very thoughtful comment. Now, coming to the Indian situation, and Kerala in particular, I don't know, I sent you this morning some numbers, but it is perhaps too early for you to look them up, but I'll take them up now. If you look at sort of COVID-19 update for India as a whole, as of yesterday, total confirmed cases, 1,194,498. Large number of recovered, there's still 41,412, 135 active cases. And the deaths have been 28,785, which works out to a case fatality rate of 2.41. As against this, there's a remarkable contrast. Kerala, total confirmed cases, 13,994 as of yesterday. Recovered cases, 5,890. Active cases, 8,057. Deaths from COVID-19, 44, which works out to 0.31%, the case fatality rate. Is there any, I mean, even if you look at India, it's a very low case fatality rate. Of course, I know you looked also for the UK at excess mortality in that period.
I think case fatality rate is, until a lot is known, case fatality rates are really more accurate only after the pandemic has been thoroughly analyzed. They're very difficult to analyze on the spot. And the reason is that what you mean by case is very different. In some people, in some countries, a case is someone who shows up at hospital. In other countries, a case might be somebody who definitely has certain symptoms and has tested positive, etc. So I think the infection ratio, that is, if you know the number of people who have actually been infected, but that too depends on how comprehensive your testing is and whether you can then extrapolate to the population as a whole. So my view is that the only figure that you can really count on at this point is the excess death per million. And excess death is the number of deaths above the average, say, of the last 5 years or so. And that gives you a better idea of what this is doing. And by the excess death, you're also measuring people who might have died as an indirect consequence of COVID. For example, there might be cancer patients who couldn't get to a hospital because hospitals were filled up, or an accident victim who couldn't be treated, things like that. So I think that's the figure to look at. But no matter what figure you look at, I think India has, I would say, a lower death rate, and Kerala has an extremely low death rate. And the death rate for India could have multiple causes. One is that we're not actually properly recording COVID deaths. So we're not able to estimate. I mean, excess death in India is probably a very hard number to get. But the number of COVID deaths, we might be missing a lot of COVID deaths because they're undiagnosed, they die at home, outside a hospital. But even so, there might be reasons why India has a lower death rate. One could be that during the summer, etc., people are outside more, where infection rates are lower. Another is that India has a demographic that is younger. than many countries.
Yes.
Then there may be other reasons. Perhaps many Indians do. We know middle-class Indians, urban middle-class Indians, are obese and have diabetes, but this is not necessarily true of the population as a whole. And so it may be that that also reduces their comorbidities. So we don't really know the reason. The one thing I would say is that Kerala seems to have done very well. And in fact, the health minister of Kerala, K.K. Shelja, is she's featured all over the place. I saw an article about her in The Guardian and the New York Times.
By Laura Spinney, remember? Yeah.
Yes, and so she's considered a kind of rock star health minister. She's become a celebrity of sorts.
Yeah, but I think particularly for saying if there's an outbreak anywhere, it's an outbreak everywhere. She, I think, asked a simple question.
I think what she did was act very quickly and produced very, very strong action from the top, very clear messaging, so people understood, very clear policy, very strong proactive measures. So these are all things that she did extremely well. And I think that is probably why Kerala has kept the infection much more under control.
Yeah, if you could go into some detail on that a little bit. As far as I can see, they gave the government of Kerala, and in particular the Chief Minister, Pinarayi Vijayan, gave 4 assurances to the people, and I think it's been well communicated and also implemented. This is, although some questions have been raised by the opposition, of course. No one would go hungry and without a safety net of essential commodities and services during this pandemic. So every agency and arm of the government, headed back by armies of volunteers, volunteer citizens, worked to deliver on this promise. Second, nobody would go without shelter. You know the agonizing part of that story where migrant workers were left in the lurch and were returning. This didn't happen in Kerala. They were given shelter, a fairly large number of migrant workers. And certainly that, I think, early on was a model for other states, which some of them caught up later. And thirdly, everyone would have access to the health system at various levels. And in Kerala, you have some attention paid to, a lot of attention paid to public health and fairly decentralized delivery of health services. And fourthly, and this is where I think the chief minister's, the equivalent to the fireside chats, the daily evening briefing, where the daily press conferences, which go to everyone, where he comes out openly. He's even said recently there is community transmission in some places, which sounds a bit ironic for Kerala, because one state seemed to have crushed the pandemic initially, and then imported cases are going up a little, still very much under control. So these things matter. My question is, why can't this be adopted more widely, particularly in richer countries, and also in more industrialized parts of India? It's a puzzle to me.
I think this requires strong leadership at the top and a very clear vision and a trust between the government and the people, and decentralization, trusting in local authorities, local health authorities, community volunteers, and so on. And this worked extremely well in Kerala, and that is probably why, because in order to do all these contact tracing, quarantining people, etc., you need the trust of the people. You need the people to feel that this is in the best interest of the community and society. They have to have a vested interest in the community. And I think that mattered a lot. I think in Western countries, especially many European countries and the United States, have not done well. And this is a little odd, because if you asked health authorities throughout the world, which 2 countries do you think would be best prepared for a pandemic, there would be the UK and the US. The US because it is very wealthy and has a broad-based medical system, and the UK because it has world-famous epidemiologists and infectious disease experts and so on. And yet they've not done as well. And I think the reasons are not entirely clear. Part of it is perhaps, I think in the UK in January, there was a big preoccupation with Brexit because January 31st was Brexit Day, and then there was a big emphasis on negotiating with the EU, the trade agreement, etc. But I don't know, but that alone doesn't explain it. So I really don't know what it is, except one emphasis seems to have been on building up hospitals, building up respirators, etc. So it may be that if you feel that you can treat your way through the epidemic, and this is Devi Sridhar's view, she's a professor of global health at Edinburgh. So her feeling was, and she said this in a testimony yesterday, that perhaps if you feel you can treat your way through the pandemic, then you don't try to crush it as much, as countries that know that they have no option. If you had a huge number of cases in Kerala, there'd be no way to treat them. It would just overrun the hospitals and health facilities. So it could be partly a matter of necessity. This is why Vietnam, for example, also did very well.
Zero deaths.
Yeah, zero deaths. Taiwan had very few deaths. So there are countries that have done well. And I think we won't know until it's over. We won't really know why certain countries acted the way they did. And, there's already all sorts of, there's a blame game going around both in the US and the UK. As you know, Fauci is being sidelined by Trump. They all want to find some sort of scapegoat if things go wrong. And I think it's a little premature. I think we would have to wait until it's all over and then try to learn lessons from them in a kind of non-judgmental way. The problem is that if you attack scientists for making mistakes, then good scientists won't give you any advice. They'll be afraid that if they've made a mistake, they'll be blamed for it later. So I think it's very important to... You
wrote about this in The Guardian, and there was that wonderful interview at the JLF London, where you spoke about it at some length about the role of scientists vis-a-vis policymakers, and how scientists should be, should be candid and honest. And if there's pressure on them, blame game. So that's
But scientists should also do two things. One is they should avoid groupthink, that is collecting around them like-minded people who won't challenge the decisions or the data or the evidence. And the second thing is they should be willing to admit when they made mistakes. I think those two things are essential for scientists to maintain the trust of the public. But the public in turn needs to understand that science is often uncertain, different scientists may disagree, and that is simply part of science, and scientists will make mistakes. Because when there's disagreement, both sides cannot be right, and yet they're both quite sincere in their beliefs about their interpretation of the data.
And you've said at the frontiers of science, there will always be uncertainty. Could you give us...
I think that is generally true, yes. Because otherwise it's settled science. It's not at the frontiers anymore.
Now, on the positive side, as president of the Royal Society, you must be very pleased that the UK is doing very well in developing, it appears to be doing very well in the field of vaccine development, and also dexamethasone, the first which went through a fairly largest trial and has been approved for clinical use.
So yesterday, at the I had to testify at the House of Lords at a select committee on COVID. And I pointed out that the success rate of countries in dealing with the first phase of the pandemic is not at all correlated with scientific ability or advancement.
That's
okay. The US and the UK, at least in the life sciences, are the two most advanced countries. If you look at Nobel Prizes or new discoveries in life sciences, they tend to dominate. But they've not done as well in the first part of the pandemic. So the first part of the pandemic, I think, has to do more with leadership and good public health measures, and has not that much to do with science. So my view is that the UK has very sophisticated modelers, but I think modeling is very useful to understand in detail the nature of an epidemic, but that's best done when you have lots of data, and that's usually when the epidemic is over. And so in the early stages, when things are uncertain and there isn't much data, they may be of limited value, because countries with no modeling expertise did rather well in crushing that first wave. But the first wave, crushing the first wave, does not get us out of the pandemic. It is simply a stopgap measure to try to buy yourself time before solutions come along. But the solutions require depth in science, and that is where Britain and the United States are doing quite well. For example, in development of vaccines, the Oxford group is one of the leaders in this thing. Britain, as you know, also made major contributions to modern statistics, Bayesian analysis, and also the randomized clinical trial, which I've criticized its overuse in cases where it's difficult to do RCT, but the dexamethasone trial is a perfect example of how RCT really can tell you whether something is working or not. And so that trial did show that use of steroids can help with severe cases and can cut deaths by a third. So I think in the future, when we're talking about vaccines, when we're talking about drugs, because I don't also think that vaccines are going to be the only answer. There will be an incomplete solution to the problem. And we will also need very good drugs against COVID-19, because some people you may not be able to vaccinate them for various reasons. There will be others who may not mount a good immune response, perhaps because of their age, and those are the people precisely at risk. So we don't know enough about how effective a vaccine will be throughout the population. And so we also do need medicines that will cure us of COVID.
On a science question, there's been a lot of reporting on antibodies, how effective will they, what will be the duration, what will they deliver, and more based on studies. And then there's more promising news about T cells, which may give you greater protection and so on. What's your take or thinking on that?
I think there was a lot of there was and there still is debate about two things. One is, if you get infected by coronavirus and you recover, then have you produced antibodies against the virus? Will you then be more immune or partially protected against a second infection? And there are, I think, one or two documented cases of a second infection. But by and large, we do mount a response. And by and large, the antibodies seem to be protective. And we also have something called T cell immunity. So antibodies that are floating around in our bloodstream are produced by B cells, but there are also T cells which protect us against foreign invaders like viruses. And so we have both kinds of immunity, it appears. what is not known is whether it's produced in, or whether it's produced in everyone. What fraction of the population is it produced in? And we also aren't sure about how long it lasts, whether it only lasts a few months or would it last a year or two. It's unlikely, based on other coronaviruses, that it'll last for a long period, like smallpox, for example, which you only have to be vaccinated once and then you're immune.
So this idea of herd immunity, which we heard about earlier on in the UK and Sweden and so on, and even in a minority of specialists in India were talking about it, that this is the only way to manage the virus. That's now dead in the water, isn't it?
I think the experience of Sweden has shown that it doesn't actually work so well, and it has not protected the Swedish economy. The Swedish economy is not doing any better than Denmark, which went into a full-blown lockdown, but Sweden has had many more deaths per capita. So I think the idea of herd immunity, if you ask the public health and science officials in the UK, their statement is that they were not aiming for herd immunity, but they were saying that if you mitigate the virus, eventually enough of the people will have acquired an infection and provide immunity, and that will slow the virus down or stop it. But they were not talking about it as a goal. But one thing is true, that they did seem to not go out for complete suppression early on. And the idea of a lockdown came only a bit later. And I think that is, we heard a very sharp exchange between Chris Whitty, who's the chief medical officer and who was responsible for some of these decisions, and Jeremy Hunt, who is the chair of the Health Committee, Select Committee in Parliament, and who was holding an inquiry. And so there was quite a sharp exchange about this. And I think we will only know post facto what the analysis is. My view is that herd immunity might have seemed rational at first sight, but it has several flaws. The first thing is, the idea was based on protecting people who are vulnerable and letting people who would unlikely to be seriously affected acquire the virus and then acquire immunity. That's the theory. But in practice, there were several problems. One is we didn't know about asymptomatic transmission. So how to isolate the vulnerable wasn't entirely clear. Secondly, it's not strictly separated by age. There are young people who get very serious illness. There are old people who survive or don't get it. So even defining who's vulnerable was not clear. So I think the way to acquire herd immunity is through science and a vaccine. That is what a vaccine does, is provide herd immunity. If you vaccinate 80% of or 90% of the population, then you effectively have herd immunity. And what these suppression measures do is buy you time until a vaccine or a medicine comes along. So I think it was a mistaken idea, if it actually was an idea at all.
It's a sobering thought that the only viral disease that has been exterminated from the face of the earth is smallpox. Edward Jenner made his seminal contribution, I believe, in 1794, and the World Health Assembly declared the world to be smallpox-free in 1980.
Yes, it's quite, and it was a massive effort. And I think we've come very close to eradicating polio.
Yes.
But unfortunately, the polio program has been politicized, and in parts of Pakistan and Afghanistan, there has been this feeling that polio, there's been all these fake rumors about the polio vaccine being some CIA plot, to sterilize Muslims or things like that. It's all complete nonsense.
Against BCG in India, and distinguished politicians also joined the campaign.
Yes, it's complete nonsense. And I think politicians and heads of government are irresponsible if they don't stifle these sorts of rumors, because they're doing a huge disservice to their own people by preventing vaccination.
So your bet on vaccines, I was leading to that.
Normally vaccine development takes many years, but it has been going at an unprecedented rate. And that is because, firstly, there's huge economic pressure to develop a vaccine, because the entire world is in a state of uncertainty. Economies all over the world are collapsing or in decline. And there's never been so much pressure to develop a vaccine. But then you have to ask, how is it that vaccines are being developed at such a rapid rate? And this is because of the investment in science and basic research over the last 20 years or so. For example, the Jenner Institute in Oxford has been involved in vaccine research for 20 or 30 years. And so they have used all of the tools they've developed and simply applied them to a new virus. So developing those tools took a very, very long time, and having all that expertise took a long time to develop. But then having those tools and the expertise meant that when a crisis came, they could quickly respond. And this may be the way for vaccines in the future, because this may not be the last, it certainly won't be the last pandemic. There'll be many more pandemics, partly because we now live in a much more interconnected world. So new viruses that pop up, which might have died out in their own locality, now have the potential to spread all over the world. So I think vaccine development does look promising. Another reason that it is promising is there are over 100 vaccine trials. And so some of them are likely to work. What we don't know is how good even the best vaccine will be. And I alluded to that, how many people will be able to benefit from the vaccine, and how many people won't be able to take the vaccine or mount a good response to it.
Yeah, we have 10 minutes to go on the agreed time. And I want to raise a question in which I think you're deeply interested. The question of uneven impact of this on different socioeconomic strata, you can say different classes in society. Professor Joseph Stiglitz, Nobel laureate in economics, will be next in this series, the Kerala Dialogue. I'll be anchoring that very soon. Has written a number of articles speaking to this subject of how terrible it is that the inequalities have increased during this pandemic. There's quite a lot of data on this, and he's written very highly critical articles on this. But do you see that as one of the problems?
There's no question that this pandemic has greatly exaggerated or exacerbated inequalities, because rich people are better able to weather the economic storm. They're better able to protect themselves from others, from even acquiring the illness, whereas those who are poor have to expose themselves to the illness, and when they get ill, they're unable to deal with the economic consequences of being ill. So this is true, I'm afraid, worldwide. It's true within Britain. Many of the people who have suffered from coronavirus have been people who have been in low-income, high-risk occupations where they've come into contact with lots of other people. And you may have heard about an outbreak in Leicester, which may have had to do with garment workers who've been crowded together and in unsafe conditions. And they there is a question about, it's not just their workplace, it's also that they live in crowded settings. Often they share the same bed. The beds are used in shifts. So someone sleeps in it at night and another person sleeps in the same bed during the day. So these are all serious problems. And every time there's a serious crisis, people say we must emerge from this and do better. We must try to reduce inequality and so on. I'm afraid I'm more pessimistic. I think, if you look at previous pandemics, well, I'll tell you, the 1918 flu,
Yes.
In the West, in rich countries, the death rate, I believe, was something like 0.5%. It was quite a lot, but not as big as India, where the death rate was 6% of the population died in 1918. So even in 1918, a poor country like India did much worse than rich countries in the West, even with flu, even though the weather in India is warmer, etc. So I think this is a very general problem. And pandemics also bring out both the best and the worst in people. So if people, well, Kerala, I think, may have brought out the best in people. People feel part of a community, they try to help each other, and so on. But they also bring out the worst. So for example, if you look at xenophobia, racism, things like that, they're getting worse, and this tendency to blame other people for the disease. So in the US, there's a strong element that blames Chinese for the disease. Well, I'm not sure the Chinese wanted this pandemic either. So, you might blame some of the officials in China, but it's not, fair to blame an entire population for it.
Yes. The issue now is, in India, we have the problem of private hospitals charging extortionate amounts. You have the advantage of the NHS. With whatever its deficiencies, it's a wonderful system, health for all, access to health for all. We do not have it, and that, I think, exacerbates the problem in India. Even if the treatment is good in private hospitals, several private hospitals, it costs, it costs many lakhs for people. In many cases, 1 lakh rupees a day if you're on a ventilator or an intensive care. And this, I think, has made it much worse. The government hospitals have done a good job on the whole, with all their limitations. So I think that it's an additional burden. It must be also the case in many other countries. But in the UK, you're lucky.
Yeah, I think the NHS has not done as well as it might have, because it has been underfunded for at least 10 years. So I think one lesson that at least the UK should learn from this is to put more resources into the NHS, but also look into the organization of the NHS to make it more efficient, to improve healthcare delivery, also to have better sort of integration between your GPs and the NHS and so on. I think these are questions that the UK is going to seriously consider. I think that no country, and especially no poor country, should be without a good public healthcare system. And this is something that, if I were to talk to the Indian government, well, it's not. I mean, it's not a rocket science. I'm sure every single person would agree that a top priority of India should be to improve its public healthcare system as opposed to the private one, which is for well-off people.
I learned that when you were invited earlier to participate in this, you said you'd be happy to, once it's possible, you'd be happy to visit Kerala and look at science there and so on. And the Chief Minister, I'm told, has extended a standing invitation to you to do that. They'd be delighted if you came and looked at what needs to be done and what is missing, the gaps and so on, advice on the scientific enterprise in Kerala. There's no time to go into it here, but I'd like to send you a list of institutions. I'll email.
Yes. The one place that I have been asked to is there's an ICER in Trivandrum, and that's the one place that I would think of going. But I'm sure there are many good institutions in Kerala, and I've always admired Kerala in some way. You know, its emphasis on literacy, on women's rights, you know, public health, and so on. So
Land
in
reform,
some
I
ways,
think,
it's a model.
Land reform earlier made a huge difference.
So in some ways, it's a model for Indian states, and so and it's geographically extremely beautiful. So there are many reasons to visit Kerala.
I'll come with you.
Oh, that'll be lovely.
So it's been a pleasure and a great honor, Dr. Ramakrishnan, to have you in this conversation. It's been very generous of you, given your busy schedule. And thank you very much on behalf of the government of Kerala, the people of Kerala, and also personally for giving us your thoughts on this important subject.
Thank you, and it's always been a pleasure. It's always a pleasure to talk to you, Ram. So it was a delight to do this.
Thank you.
Thank you.